Hey everyone, this is Jason from Intricate Art Spine and Body Solutions. You can check us out at intricateartseminars.com. I wanted to talk to everybody today about concussions. So Dr. Peter Attia, who has a great podcast, it's called The Drive. Dr. Attia, if you're watching this or if anybody knows him, I would love to be on his show and talk to him about some of this stuff. But anyways, Dr. Attia had on this PhD guy recently. His name is Mickey Collins, and he is one of the leading concussion researchers, and he deals with a lot of pro sports teams and pro sports leagues looking at their concussion protocol, like with the NFL, I believe there's their CTE concussion protocol. So that podcast was full of a lot of really, really good information, but one thing that I didn't hear was any mention about dry needling. I heard a lot of really good information about different therapy treatments focused on stimulating different brain areas to induce improved blood perfusion and to reduce the amount of spontaneous electrical random sympathetic firing that tends to go on in the brain after concussions, right? So two of the biggest problems following concussion is, remember, it's just your brain is getting bruised. It's kind of just think about it like a bruised muscle, right? So when things get bruised, they get tight, they get hypoxic, they run out of nutrients, right? And you start to get spasms in the muscles. And the same thing goes on in your brain when you get a concussion. Initially, you get a bruise, and then that leads to hypoxia in a lot of different areas in the brain, especially right in and around where it was bruised. It can take a long time to heal, so you got a lot of pro-inflammatory markers in there, like the interleukin-1, interleukin-6, tumor necrosis factor alpha. There's a lot of other pro-inflammatory markers that circulate throughout the brain and the body. So the two big issues with concussions are a decreased amount of blood perfusion in the brain and an increased amount of spontaneous electrical neuronal firing in the brain, which is one of the things that causes seizures, and it causes, anxiety, incontinence, all sorts of different stuff, right? So concussions, just like with almost all other physical and mental impairments that human beings encounter, concussions cause hyperactivity of the sympathetic autonomic nervous system, right? So when you get concussed, it's trauma, you're getting an injury to your brain. The natural response of the human body is to elevate sympathetic activity, and the way that works in our body is the sympathetic and the parasympathetic nervous system are like a seesaw, right? So when the sympathetics get elevated, secondary to trauma, the parasympathetics get depressed. The parasympathetic part of the autonomic nervous system is what helps facilitate improved blood flow throughout the brain and the body. Sympathetic hyperactivity in general reduces peripheral blood flow and has a vasoconstricting action on vessels throughout most of the body, right? So sympathetics go up, get hypoxia, we get spontaneous electrical firing of muscles, and including in the brain. Our muscles get short, they get tight, they get aggravated, right? So these are all things that happen secondary to regular injury and concussion. In concussion, we're obviously just specifically talking about the brain in most concussion research, but I think it's not that that's a mistake. It's obviously a problem with the brain. But a huge part of the problem that I think goes underappreciated is the trauma to the upper cervical muscles and joints that can prolong and amplify symptoms of concussions, and they can also cause concussive-like symptoms without any pathology to the brain. So one of the things that I disagree with Mickey about is Mickey Collins was the PhD guy on Dr. Attia's podcast. Is he didn't seem to think that the cervical spine could cause dizziness very frequently, and he seemed to think that almost all of it was secondary to brain trauma. And I'm not saying that there's no trauma to the brain, but I am saying that what I see on almost a daily basis, certainly a weekly basis, is patients that present with concussive-like symptoms, brain fog, dizziness, finding it difficulty to think, losing the ability to see a normal visual field. Sometimes you get tunnel vision type things. I've even had patients that have lost the ability to see certain colors for brief periods of time, and none of them have had concussions. They've all been from cervical pathology, right? So just the fact of getting a concussion basically guarantees that you're going to have pathology in your cervical spine, right? It would be awfully hard to get a concussion without getting some type of pathology in the cervical spine. So they're always very, very closely linked together. And I think that a big missing aspect of medicine in general is the appreciation of what we can do to the autonomic nervous system with thoughtful dry needling combined with joint manipulation and combined with some supplementation, which Dr. Attia is really, really phenomenal about talking about. A lot of these supplements that I'm going to talk about, he mentions all the time. So I'm just going to talk about 5 natural substances that are either already in our body or that we get from eating food, and how they are synergistic and how they amplify the positive effects of dry needling combined with joint manipulation to treat and resolve concussive symptoms, right? So again, we talked about concussions. The primary issue is a lack of blood flow in the brain and too much hyperactive electrical activity in various parts of the brain, depending on where the brain got bruised, right? So how does dry needling work? Well, any treatment that we perform on the human body has to work in the brain and then allow the brain to send signals and to operate different parts of our body, right? So that's why nothing that we do with dry needling is solely like in the arm or in the leg. All of it is working by stimulating a certain part of the body, which is linked to a certain part of the brain, right? So you put a needle into a certain part of the body. We know that certain parts of the brain control certain parts of the body. So you stick a little needle in a certain part of the body, that sends a signal to the brain, and the actual effect of the needling overall is from the return signal that the brain sends back to that tissue telling it what to do, right? So I think about needling as a brain treatment primarily and a physical treatment secondarily, and that's a little bit weird to think about, but everything that we do with the needles is on a base level using the brain to regulate the body, right? We're using the mind and the body's innate healing abilities, the autonomic nervous system, to heal themselves rather than try to force healing on certain things, right? So as far as needling for concussions goes, right, there's a lot of good dry needling studies looking at, and acupuncture studies looking at functional real-time MRI, so fMRI, looking at the brain for certain needling techniques for incontinence and migraines and certain other things, right? So one good example, and this is very similar to what can happen in concussions and why some people have incontinence after concussions, is that there's a part in the pons in the brain, right? So like in the deep old brain, called the PMC, the Pontine Micturition Center. And people with urinary incontinence and other types of incontinence tend to have hyperactive, spontaneous electrical firing in certain parts of the brain. So for urinary incontinence, one of the primary control centers is in the pons. It's called the Pontine Micturition Center. We can see with real-time MRI, with people with incontinence, they have hyperactive electrical firing in that part of the brain, and they have decreased blood perfusion in that part of the brain. Very, very similar to what happens in concussions, right? So by needling certain areas in the body, in real time, we can see the brain completely change as far as the electrical activity and the blood perfusion goes, right? So the brain gets inundated with new blood, get vasodilation in the brain, improved blood perfusion through the brain, and decreased spontaneous electrical firing in the brain, right? So decreased sympathetic spontaneous electrical firing in the brain and increased blood perfusion. Those are the two things that we primarily want to stimulate after a concussion, right? So Needling, the way that I look at needling is it is a specific small enough stimulus, and it's the only direct stimulus of muscles and tissues aside from the skin that we have to use in the human body as far as physical therapist goes, right? It's enough of a direct stimulus where it specifically wakes up certain parts of the brain to certain parts of the body, and it allows that connection to return, and it improves the homeostasis, right? So by reducing tissue pathology, you're giving more energy back to the brain's ability to regulate the whole rest of the body, right? So if you get a concussion, you get a bunch of deviated joints and a bunch of tight muscles in your neck. Every little millimeter of pathologic tissue is requiring energy from the brain to try to fix it, right? So that every little tiny piece of energy that the brain's trying to use to solve the pathology in the soft tissues, it can't use to help heal the brain itself, to help heal the brain itself, right? So this is what happens with chronic sympathetic hyperactivity with a lot of people is every little piece of tight tissue and deviated joint in your body is taking energy away from your body's ability to do the normal things that it needs to do, like brain function, hormone production, organ regulation, right? We only have a finite amount of energy to use. Once we reach our sympathetic threshold and we run out of energy, we go into an energy deficiency, and then our body has to make complicated decisions on, okay, well, where am I going to use this energy? Because I only have so much and I've run out, so it needs to decide on certain things to use it for, and then it can't provide enough energy or sufficient energy to maximize healing for a lot of things. And that's what happens with a lot of concussions too, right? So when you needle, especially the upper cervical spine, but this is helpful to needle throughout the whole body for concussions, and we'll talk about that in 1 second. But as far as needling the upper cervical spine goes, so we know that the trigeminocervical complex, which is interlinked with the hypothalamic pituitary adrenal axis, are big problem causers in just regular chronic sympathetic hyperactivity, and especially with concussions, right? So the trigeminocervical nucleus sits in the dorsal horn of the spinal column at C2, right? So here's the occiput. C1's in the middle, is a little wimpy guy. There's C2, right? So C2 is the first vertebrae that you can easily feel. The trigeminocervical nucleus, which is the bottom part of the trigeminocervical complex, sits in the dorsal horn of the spinal column at C2. So when we get bonked in the head or hit some way that gives us a concussion, almost always C1-2 is going to be deviated, and that's one of the big reasons why it's very, very important to check and test for subcranial instability following concussions or anything like a whiplash injury, right? Definitely don't want to have any pathology of C1-2, so that needs to be ruled out, obviously, before you go in and do any type of mobilizations or anything other in the cervical spine following some type of neck injury. All that stuff needs to be ruled out first. But as soon as we're able to, if you can go in and needle around the subcranial structures on C2, right? So on C2 you get the multifidus attaches to C2, you get the middle scalene attaches to C2, and it also attaches to the first rib. I'm going to talk more about that one in a second, right? And then you have 2 of the 4 true suboccipital muscles that attach to C2. So you get a lot of big muscles that cause a lot of problems that all attach to C2. And the trigeminocervical nucleus is in the dorsal horn of the spinal column at C2. So if C2 gets deviated, there's a lot of mechanoreceptors in the joints that pick up on stress and strain of the joints, right? We got pain receptors in our joint capsules. We got different stretch receptors. We got pressure receptors in our neck. We got baroreceptors in our carotid artery, which goes right down the side of our neck, right? So the neck has a ton of mechanoreceptors, proprioceptors, chemoreceptors, right? There's all sorts of different receptors, especially in the upper cervical spine, because our neck moves so much and we need to have a lot of sensitivity as far as temperature goes and all sorts of different stuff. Movement, rotation, right? So if C2 gets deviated, that causes the trigeminocervical nucleus to get pissed. And that starts to send negative afferent signals up into the brain. All right, everyone. So this is the trigeminocervical complex I was just talking about. So the TCC down here, that's at right around C2. So that would be the trigeminocervical nucleus, and that's like the bottom part of the complex. And then it stems up into the brain. So remember, C1-2 is the most mobile segment of the spine by far. It's got over 3 times the amount of rotation as the next most mobile segment. So any deviation anywhere in the spine is going to cause C2 to go, C1-2 to get out of place. That's going to put abnormal stresses and strains on the muscles, tendons, ligaments, and joint capsules and the joints themselves that are right around the upper cervical spine, which is going to stimulate the trigeminocervical complex, and it's going to elevate sympathetics, and it's going to cause all of the parts of the trigeminocervical complex to dysfunction, which is a big problem, right? So if you look at the ones that I really think about are the hypothalamus, thalamus, the periaqueductal gray, and the locus coeruleus. And then remember, it comes up and it stems into the cortex and the neocortex, and it has auditory areas, all sorts of different sensory information centers that are very important for our normal function and our brain function and our ability to recover from concussion, right? So one of the things that leads to further aggravation of the brain and decreased blood flow and more spontaneous electrical activity is hyperactivity of some of these areas, right? So if we go to the next page. So the areas that we're going to talk about are in the limbic system, are like the old brain, the lizard brain, right? So the locus coeruleus, or the blue spot, that's a pretty cool name for it. That's the brain's, or one of the brain's primary epinephrine producers, or noradrenergic neurotransmitter, neuromodulator producers, right? So it controls a lot of the epinephrine that's circulating in our body. And if it gets stimulated, it'll start to produce too much epinephrine, which produces more anxiety, more pain. Remember, epinephrine is a precursor to a lot of painkillers. So it just turns into this vicious cycle. If it hurts more, you have more anxiety, that causes the pain to get worse, all sorts of problems. So the locus coeruleus increases epinephrine, increases pain, decreases the amount of beta endorphin and endogenous opioids that are released. And then we have the periaqueductal gray, which is also associated with pain, right? It's thought to be one of the primary modulators of pain pathways coming and going from the brain, right? So if the periaqueductal gray gets thrown off, gets hyperactive, sympathetics get hyperactive, that's going to cause dysfunction of our pain modulation. And then we have the thalamus and the hypothalamus, right? So the thalamus is like a gatekeeper for it's like a control center, or like a server between the spinal cord and the brain, right? And then we have the hypothalamus, which is super important. It's right next to the pituitary gland. It sends signals to all of our different organs, endocrine organs and stuff in our body to produce different hormones, right? It's very important with emotions. It controls a lot of our primal urges like eating, sleeping, having sex, stuff like that, right? It's a very important control center in the brain. And then the hippocampus also, which is controlled with memory. It's primarily thought of to deal with memory. But remember, a lot of this is relatively theoretical because we don't know how everybody's brain works, but we're relatively sure that these are some basic things that some of these areas do. And again, if C1-2 gets off, somebody gets knocked in the head, they get a concussion, their upper cervical spine is going to be pissed off. The trigeminocervical complex is going to be aggravated. The stellate ganglion at the first rib is going to be aggravated. And the cranial nerves are going to be aggravated as well. Obviously, we're talking about the trigeminal nerve here, cranial nerve number 5. But if you just look at this slide real quick, so if somebody gets a concussion, like I mentioned, it's almost a for sure thing that their upper cervical spine, joints, joint capsules, musculature is all going to be very aggravated. So just look at the cranial nerves that are coming out here. We got the spinal accessory nerve, which goes right in front of C1-2. So if that gets displaced in the upper trap, which it innervates, gets aggravated, that's going to aggravate the brain very closely to directly. You got the hypoglossal nerve here. Got glossopharyngeal, the vagus nerve, number 10, obviously super duper important one. Here's number 7, the facial nerve. And then there's the base branch. Look how big the trigeminal nerve is in there. And then it goes into the different maxillary branches and different branches in there. And then remember, we also have the otic ganglion of the trigeminal nerve, which is through the little hole here in the face, which is a great place to needle. So again, this is just exemplifying the importance of taking care of the soft tissue structures in the joints in the neck and in the rest of the body to also reciprocally inhibit sympathetic hyperactivity and to allow the parasympathetic portion of the spinal column and the cranial nerves to take over and to increase vasodilation in the brain, decrease spontaneous electrical activity, and improve the speed of which people can recover from concussions and how well they recover overall. The trigeminal cervical complex, which we just went over, that starts at C2 at the trigeminal cervical nucleus, and then it goes up and the tendrils extend up into the neocortex, right? So it goes through our brainstem and through a bunch of important structures that are also in the hypothalamic pituitary adrenal axis, are also in the trigeminal cervical complex, right? So the trigeminal cervical complex does have connections in the hypothalamus, the pituitary, the thalamus, right? And one of the major structures that I think about a lot with the trigeminal cervical nucleus is the locus ceruleus is a connection in the trigeminal cervical complex, and the locus ceruleus is a primary epinephrine producer in the brain. So we know that epinephrine is a sympathetic neuromodulator. It typically elevates anxiety, right? Anxiety amplifies pain, pain amplifies anxiety, and then we just get this big negative or detrimental feedback cycle of anxiety, pain, brain fog, discomfort, more anxiety, sympathetics, and the overall result of all this is for the sympathetics to continue to elevate and for the parasympathetics to continue to depress. One of the major problems with parasympathetic depression following concussion, which happens almost 100% of the time if it's not specifically treated, is that the vagus nerve, cranial nerve number 10, right, the wandering nerve, some people call it, I like that one, the wandering nerve. That nerve goes from our brainstem down our throat, and then it innervates basically all of our organs, including our intestines. And 80% of the vagus nerve fibers are afferent. So 80% of the two-way highway on the vagus nerve are signals going from the organs back to the brain. So the vagus nerve is like our interoceptive awareness modulator. The primary job of the vagus nerve is to tell the brain what's going on with the organs, so then the brain can properly regulate the organs. So if the brain is not receiving the proper signals about the various organs, it cannot regulate them properly. And that leads to a very slow improvement following concussions, right? Because our organs play a big role in the recovery of our brain too. So we know that like our spleen, our pancreas produce a lot of immune cells, white blood cells, different things, right? They also produce pro-inflammatory markers. We know that when the sympathetics become hyperactive, our mitochondrial anti-inflammatory pathway called the NRF2 pathway gets slowed down. So all of these pro-inflammatory things that happen after concussion can be dramatically and quickly reduced with needling of the upper cervical structures, C2, and especially structures that are innervated predominantly by the parasympathetics, right? So if the vagus nerve is being inhibited, that causes significant malfunction in the brain, and it requires a lot of extra energy that the brain is trying to figure out what's going on with the organs. So if we can go in after a concussion and stimulate the vagus nerve and the parasympathetic portions of the autonomic nervous system, which we can easily do, we'll talk about that in a second, with needling, and then if everything's cleared as far as the joints and all that stuff goes, if you can put the cervical spine especially, but the entire spine back into alignment, and we'll talk about why the whole spine is important in a second, you can dramatically increase the rate of recovery following concussion. So I think that, I know that dry needling, this should be part of all of the pro sports league protocols, because I see this on a consistent basis, you guys. It dramatically improves the rate of recovery. And this is why dry needling works so quickly and so well if you do it properly for such a huge variety of impairments is because it's primarily working on the autonomic nervous system and the brain, right? It's changing the base level of the internal environment, so our body and our mind can pay more attention to certain things and heal themselves, right? So as far as needling the parasympathetic autonomic nervous system, we talked about the upper cervical spine. So in general, C2 and the base of the occiput, very, very good places to needle to stimulate parasympathetics. Up here, that's because of some of the cranial nerves. So typically in the books, people talk about, obviously, the vagus. That's the primary nerve of the parasympathetic autonomic nervous system and connects all of our organs to the brain. It tells our brain what's going on inside of our body. The glossopharyngeal nerve is considered by a lot of people to be pretty parasympathetic. The trigeminal nerve itself, the fibers outside of the brain don't tend to have a lot of parasympathetic activity, but the trigeminal cervical complex in the brain has a lot of parasympathetic dominant ganglia. So needling the trigeminal nerve is very, very helpful to stimulate parasympathetics and depress sympathetics. And the sacral plexus, so S2 to S4. And then, so remember, as far as the sacral plexus goes, S2 to S4 innervates all 9 true pelvic floor muscles, right? So that is one of the reasons why I think that pelvic floor needling should be included in basically all physical therapy patients. And it's really easy with needles if you know what you're doing, because you don't have to do anything weird with people. But those 9 muscles, if you stimulate those muscles, that is a very, very powerful parasympathetic stimulation, which reciprocally inhibits sympathetic hyperactivity, which is going to improve cerebral blood flow. It's going to reduce hyperactive, spontaneous cerebral sympathetic firing of the neurons, right? And it's just going to lead to a more homeostatic environment for the brain and throughout the whole body, so the brain and the body can heal themselves faster, right? So sacral plexus, base of the occiput, C2, and then the most direct parasympathetic stimulation that we can perform is the vagus nerve itself, right? So the one area of the body that we can easily stimulate the vagus nerve is in the ear, right? So if you look at the better studies out there, the 3 areas of the ear that are most commonly innervated by the vagus nerve are the concha, the cymboconcha, and then the inside of the tragus. So some people have those earrings on the tragus right there that go through. So the outside of the tragus is the trigeminal nerve, the mandibular branch of the trigeminal nerve. The inside of the tragus is the vagus nerve, and then the concha and the cymboconcha. So those areas of the ear are innervated by the auricular branch of the vagus nerve. That makes the ear a very, very potent place for us to utilize for basically all physical therapy patients, because basically all of them are presenting with sympathetic autonomic hyperactivity. Pain, stress, strain, trauma, all leads to sympathetic hyperactivity, right? So if you utilize the vagus nerve as a direct parasympathetic stimulation, we know that causes vasodilation throughout the body. It reduces the amount of pro-inflammatory markers throughout the body, interleukin 1, interleukin 6, tumor necrosis factor alpha. It amplifies anti-inflammatory markers throughout the body, right? And it just has an overall homeostatic effect on the mind and the body, which is, I think, the underlying reason why it helps so much with concussive symptoms, right? So that, talking about C2, so one of the reasons I mentioned that so much dizziness and brain fog and seeming brain symptoms can come almost directly from cervical muscle and joint deviation is there's a bunch of different reasons. So we talked about the cranial nerves, right? Enough negative stimulation, afferent stimulation coming from the upper cervical spine. The nerves for the true suboccipital muscles, they cross very, very close right on top of the trigeminal cervical nucleus, like all the things in our spine cross over, right? So the afferent nerves going from the muscles cross over that trigeminal cervical nucleus, and the thought is that is one of the things that causes cervicogenic dizziness, is enough negative afferent signals crossing over that nucleus. Somehow some of that electricity gets transferred and it short circuits the nucleus or something like that, right? We just don't know very much about how all this stuff works, but that's the thought right now. And I see this happen all the time, you guys. People that get diagnosed with some type of BPPV or ear canal problem or Meniere's disease or something or other, and they have all this regular good treatment and nothing fixes it, and they're dizzy for years and years and years, and then I finally get my hands on them and I needle them and I do my manipulations and they're 100% better, right? I have this happen all the time, and the reason is because there's a lack of appreciation for how screwed up tight muscles and deviated joints can make the autonomic nervous system, right? They can really have a widespread detrimental effect on the brain and on the body, right? So the vagus nerve in the ear is very good to help. And then, so the other reason that the cervical muscles are such a problem, right? So if this is, let's see, 2, 3, 4, 5, 6, 7. So here's C7T1. So this, my finger right here should be the first rib, right? Attaching C7T1. If my finger here is the first rib, this finger right here, that's the trigeminal cervical, or sorry, that's the stellate ganglion, right? So if my thumb is, if this is the first rib right here, the stellate ganglion sits right here. So that is our upper extremity sympathetic autonomic control center, more or less, right? It does a lot of different things. Some doctors still do stellate ganglion blocks with lidocaine. It used to be done more, but I think it seems like it may be coming back a little bit more. It's because if the stellate ganglion, which sits right at the first rib here, if the stellate ganglion gets aggravated, that is a very direct aggravation of the sympathetic autonomic nervous system, along with the sympathetic chain, which is the stellate ganglion is part of, right? So the stellate ganglion is typically considered the top of the sympathetic chain. It does continue up into the brain, but as far as the sympathetic portion of it goes, it typically starts at the stellate ganglion and then goes down like my fingers right on the front side of the vertebral column and into the pelvic floor, right? So that stellate ganglion and the sympathetic chain are two other reasons why it's so important to needle and perform joint manipulation after concussions, obviously if it's safe, is because if that ganglion gets pissed and it gets pulled on, it's going to stimulate the brain to go into further sympathetic hyperactivity, which is going to further restrict blood flow and cause more spontaneous electrical firing, which is going to reduce the speed of recovery from concussions, right? So we talked about the middle scalene earlier. The middle scalene goes from the first rib to C2, right? It attaches right on the back side of the transverse process of C2. Here is what I was just talking about in the video, right? So this entire nervous bundle, starting up here, going down there, there's the stellate ganglion, right? So there's the star ganglion right there. There's some information about it if you want to read about it. So this is what I was talking about. So this is typically considered, aside from the brain, the top of the sympathetic autonomic nervous system. And this stellate ganglion can give the upper extremity unusual radicular symptoms, stress on the sympathetic chain, anywhere from here up to the head, all the way down to the coccyx, can put stress on this ganglion that can cause brain fog and cause all sorts of sympathetic hyperactive problems, hormone disruption. I mentioned here's the middle scalene, right? So if that gets tight and deviates C1 and or C2, that's going to put stress on the stellate ganglion and the rest of the sympathetic chain. And then if you follow the sympathetic chain down, this is the entire sympathetic chain, right? So it goes from the stellate ganglion right there, right? And then if we follow it down, it goes all the way down towards the lumbar spine, and then it continues on down through the pelvic area and all the way down into the pelvic floor, right? So this is just an extension of that same chain. So this is what I was talking about, you guys. If the spine gets deviated anywhere, deviated enough, including the pelvis, it's going to put tension, abnormal stresses, and strain on that sympathetic chain. And then again, see how the psoas major, look at, there's tendrils of that sympathetic chain that go directly through the psoas major, and they also continue around the backside into the multifidus. So if we just zoom in here a little bit, look, there's tendrils of that chain. There's the multifidus. So the multifidus and the psoas major are basically touching each other, and they both have direct tendrils of that sympathetic chain going through them. So the psoas major is obviously in the pelvis and lumbar spine. If we zoom out, the multifidus goes from C2 all the way down to S2, and then the sympathetic chain is right on the opposite side of the vertebrae from the multifidus. So if the multifidus gets tight, pulls the spine out of orientation, deviates the ribs can directly push on the sympathetic chain if they get displaced. That elevates sympathetic autonomic nervous system activity and causes widespread dysfunction of the nervous system. So again, just because the pelvic floor may not be an area of complaint for somebody, it's vitally important to treat, because if you don't treat the pelvic floor, you're missing a huge percentage of the autonomic nervous system regulation that you could induce with your patient. Okay, so the middle scalene, which we just looked at, that goes from the first rib to C2. If that gets tight and aggravated, that can both deviate the first rib upwards, which is going to put stress right on the stellate ganglion, which is right on the front of the first rib, and it's going to pull C2 out of the place, which is going to aggravate the trigeminal cervical nucleus in the dorsal horn of the spinal column at C2, and it's going to start to send aggravating afferent signals from the suboccipital muscles that attach on C2, which those afferent nerves go right over that trigeminal cervical nucleus, which is going to further piss that off, and then we're going to have all sorts of brain dysfunction. The locus ceruleus is going to start to get stimulated. The hypothalamus and the thalamus are going to start misproducing concentrations of certain hormones and neuromodulators. There's going to be widespread problems throughout the entire brain and body, right, secondary to just simple things like aggravated muscles and joints, leading to aggravating nerve ganglia that are going to aggravate the brain, right? So again, there's lots and lots of good studies showing how regulatory dry needling is on the brain when you target certain areas of the body. And this is one of the reasons that I think it should really be used in concussion protocols, and it should be much more widespread used in all of medicine, including mental health, because of the dramatic homeostatic healing effects it has on the brain, right? Okay, so we talked about the pelvic floor a little bit. We talked about the middle scalene. One of the other muscles that I really like to focus on, or a couple of the other muscles I really like to focus on for concussions, are the multifidus. So I always say when I'm teaching dry needling, if I had to pick one muscle in the body only to needle, I would pick the multifidus. If I had to pick a number 2 muscle only to needle, I think I would pick the psoas major. And the primary reasons that I pick those 2 muscles are they're the closest muscles to the nerve roots that come out of the spinal cord, and they're the 2 closest muscles that we can target that are closest in proximity to the sympathetic chain. So again, when I'm treating all of my patients, I'm always thinking about how can I regulate the autonomic nervous system as much as I can towards neutral, which is almost always going to involve depressing sympathetics and stimulating parasympathetics, right? So that is one of my base lines of thought for all of my patients, right? I think if we focus on treating the nervous system and the brain itself rather than treating the specific impairments, you get much better overall results, right? So the multifidus sits in the lamina, goes from C2, another big one that attaches to C2, all the way down to S2, right? So it's the muscle that's closest to the sympathetic chain on the backside of the vertebral column that crosses the most of the spine. One of the problems with the multifidus when it gets aggravated, or after you get a concussion and you get your neck wrenched around, is the multifidus gets infiltrated with adipose tissue, right? So the multifidus is it's the backstrap muscle of wild game. Like for elk and deer, the multifidus muscle is a very good muscle to eat. And I think one of the reasons is because it gets infiltrated with fat tissue. The problem with humans when it gets infiltrated with fat is the multifidus is a slow twitch muscle, and it's an opposite side rotator. It's the most important stabilizer of our spine in the back, right? So if the multifidus gets infiltrated with adipose tissue, which it's been shown to do for any type of aggravation to the spine or pain in the spine for any period of time, the multifidus starts to get deficient because it gets up to 50% infiltrated with adipose tissue. So if we lose our most important stabilizer that's supposed to be working and firing low grade all day long, right? What happens is then our bigger, more fast twitch muscles try to take over for what the multifidus is doing. So our muscles like our paraspinals that are here, our trap, our lat, our QL, all those muscles try to take over for what the multifidus is doing, and then they get pissed and they get hypoxic and everything gets tight and it just crushes the whole spine together, right? And remember, it also puts a ton of abnormal stress on the sympathetic chain, which is right in front on the anterior lateral portion of the vertebral body. So if you get any type of deviation anywhere in the spine, that's going to put stress directly on that nervous bundle that's on the front side of the vertebrae, which attaches to the stellate ganglion, which goes up into the brain. We're also going to have C2 deviations, which are going to aggravate the cranial nerves, right? And the vagus nerve is going to become severely inhibited. The intestines are going to lose their motility. Our serotonin production in the intestines is going to go down, right? We know the intestines are so important for mental health, that if the vagus nerve is inhibited, the intestines are inhibited, that's going to inhibit brain recovery and concussion recovery, right? So there's a lot of different ways to think about how needling helps with concussion. Oh, the other thing I want to talk about, sorry, the last thing, the QL. The QL and the middle scalene are like opposite muscles, right? So the QL attaches the 12th rib to the iliac crest and the lumbar spine. The middle scalene attaches the cervical vertebrae to the first rib, and one of those is C2, right? So if the scalenes and or the multifidus first get tight, almost invariably the other one's going to get tight, because if the scalenes get tight first and they pull the first rib up and the rib cage up, then the multifidus is going to get pissed and the QLs are going to get pissed and they're going to pull down on the rib cage, and then you're going to have tension from either end of the rib cage, and that's going to cause the first rib most likely to deviate upwards out of place, and that's going to put tension and stress right on the stellate ganglion there, again leading to all sorts of autonomic hyperactivity, decreased blood flow in the brain, decreased ability to heal, decreased immune function, right? These are all things that happen following concussion and following just regular chronic sympathetic hyperactivity. It's just a little bit more obvious typically in concussive patients, right? So all of these things are very helpful for concussion patients, you guys. I played Division I ice hockey in college. I've had a lot of experience with this type of stuff, and it's really helpful. I've seen it in so many patients. And again, it goes very well in line with the podcast of Dr. Peter Attia's on concussions, and we've included a link with that here, you guys. So check out that podcast. Think about what I said. Let me know if anybody has any questions about anything. Thanks for watching. See ya.